So our first, why don't we get on with it? We've got a great group today. Our first speaker is Dr. Barbara Testoni from the Cancer Institute of Lyon, France. And Dr. Testoni needs no introduction here. She's one of the preeminent authorities on the molecular biology and clinical hepatitis B disease with numerous papers. I have them all open from list, but I don't want to eat into her time. So Dr. Testoni, we look forward to your talk.
Well, thank you very much, Tim, for this kind introduction. I really feel honored to open this workshop. Thank you very much to the ICE-HBV Coalition. So the purpose of my talk is to give you a summary and an overview of the serum biomarkers of viral replication in order to introduce all the other talks. So as most of you know, hepatitis B can cause a chronic infection which can lead to severe liver disease culminating in hepatocellular carcinoma, which is ranked the third among cancer deaths worldwide, and the large majority of these HCC are due to hepatitis B infection. The current antivirals need lifelong therapies to maintain efficient viral suppression. Why? Because we still have some gaps in order to obtain full HBV elimination for the liver of infected patients. In particular, we have to cope with the intrahepatic HBV viral reservoir, the long-lived cccDNA, which sustains a high viral antigen load, and also the fact that we have defective innate and adaptive immune responses. So let's go to the virus. So I will not have time to dissect all the HBV life cycle, but there are some key points that I want to remind you. So the first is that once the virus enters the cells, so its nucleocapsid is trafficked to the nuclear, where around the nuclear pore, it is able to release the genome in the nucleus of hepatocytes, and the so-called covalently closed circular DNA is formed. cccDNA is the key molecule of HBV life cycle and is responsible for the persistence of the infection in the liver. It is a mini chromosome, and it is a epigenetic. Yeah.
Sorry to interrupt you, but we can only see the first slide, your title slide. Can you try to solve that? Excuse me.
Yeah, no.
No, it's fine. Perfect. Yes.
Oh, great.
Thank you.
I'm sorry for that. And so cccDNA is a mini chromosome which is epigenetically regulated, which means that two different cccDNA molecules can have different activity according to their epigenetic and chromatin status. Another key point is that HBV replicates through an RNA intermediate, which is fundamental. And this RNA intermediate, which is called the pregenomic RNA, is then retrotranscribed into the DNA viral genome. Moreover, HBV can integrate in the host genome, and these integrated sequences do not account for viral replication, but can produce RNA and proteins. So if we switch to this type of representation of the cycle, it is clear that when we treat patients with NUCs, which block the retrotranscription step of the viral life cycle, cccDNA is not touched, and also the production of RNA is not touched by nucleoside analogs, which means that the transcription of cccDNA is still active and antigens can be produced. So this leads to this type of situation where under NUC therapy, serum HBV DNA and HBV replication is profoundly suppressed, but antigen, in particular S antigen, continue to be sustained by cccDNA transcription and also by integrated sequencing. So what do we want now? What do we need to achieve to eliminate HBV? So of course, the holy grail would be a sterilizing cure where both cccDNA and integrated sequences are eliminated, or a complete cure where cccDNA has been destroyed. But more reliably, what we can imagine we can achieve in a hopefully near future would be a functional cure where the antigen load is profoundly reduced, and in the liver we live with very, very low cccDNA and inactive cccDNA. So what should be expected from an ideal HPV biomarker that could lead and help us in this path, which is with non-invasive? It should be helpful in identify treatment response before beginning of the treatment or early during the treatment. It would be helpful to stratify patients according to their disease stage and the risk of complications, and also in the management of patients in the choice who must be treated and when the treatment would be stopped. And of course, it should reflect the intrahepatic cccDNA pool and activity to predict the functional cure, HBs loss, or a complete cure. Of course, the gold standard would be to go directly in the liver and assess the cccDNA and transcriptional activity, but this is obviously hampered by the invasiveness of this technique and by the technical limitation of looking only in a small portion of the liver. So what we have now in terms of viral serum biomarkers, we have serum HBV DNA and HBe antigen. What are they? So serum HBV DNA is the DNA which is contained in the infectious virion circulating in the serum, and it is directly derived from the retrotranscription of the pregenomic RNA, which is uniquely produced by cccDNA. HBe antigen is also the product of the translation of the precore RNA, which is another longer than genome RNA, which is exclusively produced by cccDNA. So HBe antigen is associated to high replication and infectiosity of the virus, but it can also be lost during the HBe antigen negative phase by the selection of defected viruses. So in particular in HBe antigen negative patients, HBe antigen negativity does not mean that the virus is inactive. So serum HBV DNA is the hallmark of infection, and the suppression of serum HBV DNA is be correlated with significant lower risk of hepatocellular carcinoma development. However, long-lasting HBV DNA suppression induced by nucleoside analogs does not eliminate completely cccDNA. As you can see here, after 10 years of treatment, you still have some cccDNA in the liver. Moreover, what we know now is that the serum HBV DNA suppression under NUC is not complete, since some virions are still produced in the liver, and probably we have a need for a more sensitive assay that could help in the assessment of viral suppression and in particular during the development of new antivirals. So HBe, serum HBV DNA, together with liver injury markers like ALT levels and fibrosis and liver inflammatory scores, are now used to classify chronic hepatitis B into phases 1 to 5. I won't enter into the details because Harry Johnson will talk about that after, but I can say that this classification as a classification does not completely reflect the complexity of the panel of the chronic hepatitis B patients. And as you can see here, you have also the S antigen, which is depicted, which is not taken into consideration for the fully into consideration in this classification. So what is HBs antigen? HBs antigen is a group of 3 proteins which are produced from cccDNA, but also from integrated sequences that constitutes the subviral particles and also the envelope of the infectious virions. So nowadays, the quantification of HBs antigen is pivotal in the diagnosis and the follow-up of the patients. You can see here the 3 proteins. The S is the smaller one, then you have the medium and long. The quantitative assay used nowadays detect an epitope here in the S proteins, meaning that they detect all the forms. So HBs seroclearance is used as the standard definition for the functional cure, which is the goal for the actual new therapeutic strategies. And HBs levels also contribute to hepatocellular carcinoma risk, in particular in patients with low HBV DNA. And most of all, HBs loss allows the safe discontinuation of antiviral therapy, meaning that we have an immune control of the viral replication. But this concept has been recently challenged, asking if we really need HBs antigen loss to stop therapy, which was presented recently at the EASL by the Stop-NUC study by Van Bommel. So, what do we need? What do we need to know? We need a surrogate marker for HBs antigen loss to be used in early phase clinical trials. Could it much of its decline and how fast? By principal component analysis, you can clearly discriminate HBe antigen positive and negative patients, and when you had the correlated antigen and the viral intrahepatic markers, you can discriminate a third group of patients which is been not identified by viral load or HBs antigen alone, that has high cccDNA transcriptional activity and high fibrosis and necroinflammatory activity, meaning that correlated antigen as an example of how it can improve the classification and discrimination of patients. However, correlated antigen is limited in use for the HB antigen positive patients due to the fact that it recognizes also E antigen, and probably we need for a better sensitivity of the assay. Then we have the circulating HPV Rnase, which have generated a lot of literature in the last 2 years. So Rnase is the direct product of the cccDNA transcriptional activity, but also from integrated sequences. And it was an old observation that we can detect some HBV Rnase in the serum, and really it has been developed a lot in the last few years. What we know about circulating Rnase, it has been shown in humanized mice that correlate with cccDNA transcriptional activity in the liver. They differ among chronic hepatitis B phases, and they may help predict responses in interferon and interferon plus NUC treated patients, and they are very useful in predicting HB antigen loss in HB antigen positive patients. However, this is only a non-exhaustive list of the references and the literature about the different species that could be found circulating, and also where they could be found. So the general idea is that most of the circulating RNAs are derived from progenomic RNAs and are found in virion-like particles, but probably it's not all that. Moreover, if we add this heterogeneity to the fact that they can come both from cccDNA and integrated sequences, and that the way different labs are now assessing the quantity of this RNA, which is really well resumed in this review, we can really easily imagine that according to different quantification strategies, the biological and clinical significance of this biomarker can be very, very, very different. And Van Bommel in his talk will talk about that. So to conclude, I would only to pay attention to one point. So we have now at least 4 biomarkers that we can use to follow HPV infection, but we have to be careful on how we use these biomarkers and how we interpret their kinetics and their variations in order to really distinguish between if they are telling us the target engagement of the drug that we are using versus the endpoint prediction. What does it mean? I make an example. For example, when we use capsid assembly modulators, we interfere with the assembly of the nucleocapsids, therefore also with the production of infectious virions. And of course, what we have is a decrease of a serum HBV DNA, is the decrease of correlated antigen because we have a defect in the capsid assembly, but we may see also a decrease in circulating RNA, which can be due by the fact that most of this RNA is encapsulated in the serum. So this means that this decrease in RNA is a consequence of the target engagement of our drug and not a consequence of a direct effect on cccDNA quantity or activity. So really we have to pay attention, and the idea is that no one biomarkers will fit all new treatments that will be evaluated for HBV, and we have to be very careful and in the design of the use of these biomarkers, and we definitely need new translational studies, more translational studies to really assess the value of these biomarkers in the light of new treatments. And probably we will need an integration assay between different viral biomarkers and also with immunological biomarkers. And that's all for me. Thank you very much for your attention.
Thank you. Thank you very, very much, Dr. Testoni. I don't see any questions coming in the chat box, but I'll ask if you were going to be running. We have a couple minutes before we go on to our next speaker. Can you say which of them? I was curious to see that you mentioned the L and M hepatitis B surface proteins. Could you just touch again on what you think they may reveal that the HBS alone, just subviral particle, doesn't reveal? How can they be used?
Yeah, so indeed they were two very nice studies, and so the three different proteins can have indeed a different regulation coming at the level of transcription, because they have unique promoters, but they have three different transcriptional start sites, so they can be regulated differently, but also they also have a different post-translational and post-transcriptional regulation. So indeed, I think we need more basic science knowledge about that, so how they are really finely regulated. But definitely, it seems that the discrimination between the two long forms with respect to the overall S-bird serums are associated to the risk of developing hepatocellular carcinoma, which is a pivotal point. Nevertheless, the heterogeneity of these splice variant species is huge, and still we don't know what they mean and how is the biological significance of these species. So yes, of course, we have to take them into consideration, but we have really to put an effort in understanding where do they come from and what comes from integrated cccDNA, which is a major gap in our understanding and in our comprehension of the HBV biology and also clinical consequences. It depends. It depends. Regarding the L and M, I think we cannot exclude it. The formal proof of it, since really characterizing the full HBV integrated sequences in a genome, it's quite a challenging task, even if the single molecule sequencing study presented by Gilead at the EASL began to do this type of analysis.
I agree. I'll close just by echoing maybe what Jamin was getting to in my question, that L might be a good bet for a discriminator, better than S if you have to choose. But with that, and I know there'll be opportunities for more discussion later, but I want to really thank you, Barbara, for a great summary